Okay, good evening, everybody. Welcome to this another session of 49th Comprehensive Course on Echocardiography. We have come a long way in understanding the basics of MO, 2D, and Dopplers, followed by chamber quantification and measurements. Now, what we are going to see is the clinical application of all this, which we have learned in last almost 4 lectures, followed by an examination. Today, I'm going to deal with a few of the stenotic lesions, that is mitral stenosis and tricuspid stenosis. That's what I'm going to do it today. Majority of our lesions presenting in our circumstances, though we belong to still a poor class country or progressive country, not a developed one as on today in the world, we are exposed to the lesion of a rheumatic heart disease to a large extent. People practicing in big cities like Delhi, Mumbai, Chennai, Kolkata, and other major cities, they hardly happen to find these people suffering from mitral or other stenotic lesions. But when we encounter the people who migrate from other part of our country to these major cities, we do see a lot of these rheumatic heart disease lesions. So today we are going to talk about 2 of them as of today, mitral stenosis and tricuspid stenosis. I will try to be as brief, as simple as possible, because my quest is you should understand how we should able to assess mitral stenosis and how do we classify them as severe, very severe, and progressive. That's what the classification based on 2016 guidelines. With these few words, let me move on to my presentation on mitral stenosis. Whenever I deliver this topic, I always say these words: mitral stenosis and its evaluation and when to intervene. Because all of us are clinicians and we happen to understand whether this stenosis is at the level of intervention or at the level of medical management. That's what our aim is. Well, if you happen to look at the slides, almost 90% of the lesions are single-handedly mitral valve lesions. Almost 20% are when they are associated with aortic valve. Isolated aortic involvement is very rare. And we can have multivalvular lesions in the sense all 4 valves could be involved in the same patient at the same time. And whenever we have the involvement of these left-sided valves, we are bound to have a pulmonary artery hypertension as one of the criteria for severe pulmonary mitral stenosis is when you have a peak systolic pressure of more than 30 millimeters of mercury. How do we look at them? That's the most important thing is we look at them by looking at the anatomical informations. Then we go for the functional informations. Look at a color Doppler flow like turbulent beam or a jet of mitral flow and follow various Doppler echo calculations which we do in these subset of populations.
No video seen
When
in
we
the
do these
screen,
kind of applications in these populations, we do many calculations in these subset of populations. And that's what we are going to deal with in a time to come. Let's move on one by one. As we understand, majority of these stenotic lesions, they present with thickening, fibrosis, and calcification. Opening is restricted, and a very important sign is doming and diastole. And whenever the area is narrowed or the flow is narrowed, turbulence happens and the gradients goes high. So our goal is to confirm these diagnoses and what is the method with which we do it. We go on to look at these populations by looking at plaques window as well as apical four-chamber window. Look at this valve. It's a very category, if you see this valve is doming in diastole. Look, it's doming in diastole. It's a hockey stick shape of the mitral valve leaflets. And why do they happen? Because we have a primary cords attached to the tip of the mitral valve leaflets, and we have a secondary cords attached to the body of the leaflets. When valvulitis happens, so what happens next? These valvulitis leads to significant mitral regurgitation, and when these valvulitis heals, they lead to a fibrosis. And when the fibrosis happens, there's a shortening of these cords, and when shortening of these cords happen, you do not see an adequate opening of these valves. Well, this opening can be restricted to some cases in the myxomatous valves also. But in those cases, we do not find this classical hockey-shaped structure because there is no involvement of a cords in those myxomatous valves in the sense they never get fibrosed. They are hypermobile cords are there. They'll not produce stenosis. The fair chances is they'll produce regurgitations. On top of that, AML is a large leaflet, whereas a PML is a small leaflet. When the cords of the PML get fibrosed, the opening of the PML gets restricted. Now look at this opening of the valve, which is quite significantly restricted. And on the other hand, in four-chamber view, we hardly see any opening seen in this particular part of the view. And look at the LS size. LS size is large. If you have to measure this LS size, which we taught you over a period of time, this LS size is quite large in this subset of population, and so is over here. Third important thing is, look at this aortic valve. The aortic valve looks to be thickened in this subset of patient. It means he belongs to almost that category of 20% of populations where aortic valves are also thickened. Most important thing is the spontaneous echo contrast in LA. Look at the LV, look at the LA, and you find lot many echo densities in left atrium because of the stagnation of flow. Here, the same thing can be seen over here. And one of the most important signs when we go for quantification, apart from these anatomical features, is the restricted opening of this mitral valve leaflet, and we can measure the size of the opening during diastole, and normal is more than 1.2 centimeter, and when it's become less than 0.6 centimeter, we often say possibly we are dealing with severe mitral stenosis. So this is what a doming, again, hockey-shaped during diastole is a classical rheumatic heart disease. And now you can see in a zoomed view how thickened these valves are, how thickened the aortic valve is, and possibly there's a clot lying in the LA free wall over here. Next comes thickening can happen for many other conditions. Look here, the thickening is present, but there's no doming of the mitral valve leaflet, and there's an echogenic mass in the LV apex also. Thickened leaflet, echogenic mass in LV apex with normal systolic contraction. Remember, one very important criteria in echocardiography is if you have mass in the apex and you suspect acute interval MI where the apical segments are involved, the segments has to be hypo or akinetic. Presence of a mass or a thrombus or anything else, in the absence of any apical hypokinesis, we have to really look at the cause why it's happening. This is a diagnosed case of hypereosinophilic syndrome or Loeffler syndrome, which is quite commonly seen in our country, patient presenting with right-sided heart failure. And these people, they do not have a significant stenotic lesion. They have a significant regurgitant lesions. Another very important category of these people of mitral stenosis is when we have an atherosclerotic mitral valve disease. Now look when this slide plays carefully. What is the difference between atherosclerotic and rheumatic heart diseases? In patients of a atherosclerotic valve, the most important thing is they have an annular thickening. They don't have a significant valvular involvement in this subset of population. Look, you can see very carefully the movement of these leaflets. This is AML, this is PML over here. The leaflet movement is significantly present, but there's a significant annular calcification, which is seen both on medial side as well as lateral side. And the annulus also, the significant annular calcification is present. The reality of this mitral stenosis is when we have a normal valves, but the leaflet or the structure distal to the valve leaflets, they are fibrous or stenotic. What we call them as subvalvular apparatus. If I go back to my previous slide of a plaques view, I should be able to explain you what we mean by subvalvular apparatus. Look, these valves are attached to the body of the papillary muscle through cords. One variety is where we have valvular lesions. In some of the cases, the valves remains okay, but the subvalvular apparatus in the form of cords as well as papillary muscle, and preferably the cords, they get inflamed and finally gets fibrosed. And when you see this kind of a phenomena, what do you see? You will see a significant turbulence, not at the level of valve, but at the level of cords. And this is one condition. If you happen to measure the mitral valve area, it will be normal. But gradients would be significantly high. So remember, if you have a patient of mitral stenosis where gradients are high and the area is normal, think of a subvalvular stenosis as one of the cause of incident. Now, this is very categorically seen of a subvalvular apparatus thickening. Look, here's the valve leaflet in three-dimensional chamber, and look at the subvalvular cords, which are thickened, and they're hardly opening up. And if you look at this carefully with this particular image, look, the turbulence is at the subvalvular level, not at the valvular level. Look, the turbulence is at this particular point of a subvalvular lesions. Next is a parachute mitral valve. These parachute mitral valve, they behave like a mitral stenosis. What do you mean by parachute mitral valve? All the leaflets of AML and PML and these cords, they are attached to single papillary muscles. So you look at this stenotic kind of a lesion out here, and on top of that, if you go to short axis view, you will find only one papillary muscle as seen over here. The lateral papillary muscle is seen, the medial is lost completely. And this is a congenital heart disease presenting like a parachute mitral valve. Again, an example, look at hockey-shaped structure of the mitral valve leaflet for this particular phenomenon. And this case of a mitral stenosis shows significant restriction and a clot formation in the left atrial appendage. Now, this clot, which is so freely mobile in this left atrial appendage, many of you will feel that if this gets embolized, when the God gives you something, it also gives you something restriction also. Look, the blood cannot get through these valves. How can this thrombus get out of these valves? So we have a couple of pictures where a large rounded thrombus, which is working or looking like an hockey stick kind of a structure, moving in and out into the left atrium, but not able to go through the mitral valve leaflets. So one feature, remember, apart from anatomical, is a cusp separation less than 6 centimeters is suggestive of severe mitral stenosis. In mitral stenosis, the most important part is mitral valve area by planimetry. And look, this is a short axis view at mitral valve level at third intercostal spaces. They look like a fish mouth opinion. Here is a lateral annulus, here is a mitral annulus. This is AML, this is PML. So this is AML, this is lateral annulus, this is medial annulus, here is the PML. AML is always bigger than PML. Look at your lips also. Your anterior lips are much bigger than the posterior lips. And that's what the God has given to these mitral valves too. The most important part of this mitral valve area is the assessment of this mitral valve area. We'll come to them in a couple of minutes. Let me go to the certain important thing which has been used in the past for a long time, and people do ask them again and again. Whenever this mitral valve leaflet opening will be restricted, this is D slope or D excursion would be reduced. Then the slope of EF, which is significantly reduced. Next important thing is, if you look at an LV, LV would be always normal in size, where LA would be always large in size. And if you happen to find that LV is larger in size, please look at the mitral regurgitation or aortic valve regurgitation also in the same group of patients. I have told you already what is the difference between subvalvular and subvalvular lesion. Here is a valvular lesion, here is a subvalvular lesion. And here we sometimes find a membrane which works like a supravalvular lesion, and it behaves like an obstruction which is not at the level of valve but just below the valve in some sort of populations. When we put a gradient, when we put a continuous wave Doppler across this mitral wall levels, what do we get? We get a Doppler spectrum pattern, something like this. And that's what we taught you over a period of time. Look, this patient is in atrial fibrillation. He has got an E wave, but there's no A wave. So we trace this Doppler spectrum pattern. And if it's an atrial fibrillation, we do it in 11 times. And take the average of those 11 segments altogether. Once we trace this Doppler spectrum pattern, what do we get? We get the maximum velocity, we get the mean velocity, we have peak gradient, mean gradient, velocity time integral, and on top of that, the heart rate. And then we look at the pressure half time of these subsets. We put a sample volume from this point to this point and measure the pressure half time. So what exactly did we look at? We looked at the mean gradient, we looked at the pressure half time, and then we looked at the mitral area by pressure half time as well as planimetry. If I have to put them all together in one single chart, what is the most important thing is mitral area by planimetry. Anything less than 1.5 is considered as severe versus very severe. More than 1.5 is considered as progressive. And this is where you can really manage this patient medically. Pressure half time more than 220 is less than 1 centimeter square. 150 to 220 is severe mitral stenosis, and less than 150 is progressive mitral stenosis. The mean gradient has to be more than 12 millimeters of mercury. What do you mean by mean gradient? You trace this Doppler envelope, look at the mean gradient 9 over here, 7.3 over here, 9.12 over here. Join club, add them together, divide by 3. They'll give you an average of 3. So these mean gradient has to be more than 12 millimeters of mercury. LA enlargement has to be there definitely. And then we look at the peak velocity, peak PRZ gradient, it should be more than 30 millimeters of mercury. Issue is, what is the strategy between very severe and severe? If you look at very carefully, here is less than 1 centimeter, here is 1 to 1.5 centimeter. And many people, if they do not understand this particular language of AHA ACC 2014 guidelines, they always question work, why do you call this as very severe when it's severe? Prior to 2014, we always used to call them severe. Now we call them very severe. A person who has got a mitral area by planimetry, not by pressure half time, area by planimetry less than 1 centimeter square, pressure half time more than 220, mean gradient more than 12, large LA, peak pulmonary artery pressure of more than 30 millimeters of mercury, symptoms or no symptoms, this is where surgery is needed. And how the surgery is needed? There are multiple reasons like how the surgery is needed. If this is 1 to 1.5 centimeter, pressure half time between 150 to 220, mean valvular gradient is between 5 and 12, LA enlargement is there, peak pulmonary artery pressure is there. If those people are symptomatic, they always go for surgery. The word should be symptoms has to be there to go for surgery in the subset of populations. After that, whatever you say, rest all belongs to progressive, and there was a time when we used to call them as mild, moderate, and severe. People of the age of Dr.
इनको खाना दे देना मैं जा रहा हूँ अंकल के
still
यहाँ
understand these people as mild, moderate, and severe. But the people who belong to the age of Yogesh Ajmera, they always considered as severe, very severe, or progressive. And that's how they work in mitral stenosis as on today. On top of that, we add certain things in our armamentarium at Jorop Institute. We say if your mitral cusp separation is between less than 5 millimeters, we always talk of a very severe mitral stenosis, and symptom has to be there There's no way the symptom is not there. Whether symptoms or no symptoms, we operate them. In severe, cusp separation is 5 to 8 millimeters, and symptoms has to be there before we operate or intervene in these people. Anything more than 8 is considered as progressive, and symptoms are hardly any in this subset of population. Only fact is which we never look in these populations. When we get affected with rheumatic heart disease, these people are nutritionally deficient. They may have anemia, they have a B12 deficiency, they have a folic acid deficiency. They have all kind of a deficiency in their body. So what you need to do is to correct their deficiency. And believe my word, somebody who has got anemia, if you correct his anemia, obviously not the mean gradient will fall, but certainly the peak gradient will fall, and the patient will be less more symptomatic than the previous times. Now the next question comes, how to calculate the mitral valve area by pressure half time. What do we do is, as I showed in this graph, you trace the Doppler spectrum pattern and then put a line from this point to this point. What happens once you put a line from this point to this point is, we call them the time taken for this pressure to drop to half is known as pressure half time. Suppose the pressure over here, for calculation purposes, suppose the peak velocity over here is 3 meters per second. 3 into 3 into 4, 36 millimeter is a peak pulmonary artery pressure. How much time it takes to drop to 18 millimeter, that is the pressure half time in this subset of population. And whatever the pressure half time is, 220 divided by pressure half time will give you a mitral valve area. You look at this slide which I showed you a few minutes back. If this area is more than 220,
नहीं ये रख लो गाड़ी में रह लो तुम आओगे गाड़ी से ही ना रैबलेट खा लेना रैपटैप
look at this slide over here. If the time is more than 220, my area is less than 1 centimeter square. So anything 220 divided by pressure half time will give you a mitral valve area in this mitral stenosis. So now the same patients where we have done a flow turbulence across this mitral valve levels, we did a Doppler spectrum pattern which shows the patient is in atrial fibrillation, and we got the peak and mean gradients over here. The mean gradient is between 7.3 and 9.12. So 7.3 to 9 millimeters of mercury. And then we dropped a line from a top to bottom, and that's what we got the pressure half time in this subset of population. And this pressure half time divided by 220 will give you a mitral valve area. Now, number of times what exactly happens in mitral stenosis? We do not have a slope which is linear. As you say, we say that non-linear slope. Look, this is very carefully. There's a large beaking of this graph or Doppler flow pattern over here. So where do we measure? We don't measure from this point to this point. We ignore this peak and start measuring from this point, goes up to the base to look for a pressure half time. Next is this patient is in atrial fibrillation. So we cannot depend on one line or one measurement. We start looking at a graph which has got a longer deceleration time. I'm not going to take a deceleration time in this, nor in this, nor in this. I'll start looking at this kind of a formats to look for pressure half time to get an average of these pressure half time. But remember, if it's a case of atrial fibrillation, this pressure half time by Doppler flow will not give you accurate value ever. So spend and depend on planimetry area for a pressure half time. So this is what I mean to say was 2 dimensions area by pressure half time. When we look, planimetry is when we have an area from short axis view, how much this area is. Now, it's very difficult how do you say my mitral valve is fully open or not fully open, and how do I say my mitral valve area is? So much so, because if I look at this short axis view, I may be over here, I may be over here, I may be over here also. So how do I be very sure that I am at the tip of the mitral valve leaflet? Fortunately, this issue has been addressed very easily by a new generation 3 dimensions echocardiography machine, where they started looking at these in 3 dimensions echocardiography. What is this 3 dimensions echocardiography is? This is known as biplane in G and X-plane in Phillips. You can see the cut line where you are cutting this mitral valve area at the tip of the mitral valve leaflet. Same thing in orthogonal plane would be seen in a short axis view with the mitral valve area, which is the orifice. Earlier, we used to go from papillary muscles back and try to see the first structure which is opening up is the mitral valve area. Now we can see with our eyes, look, this is where we cut down and we get a mitral valve area by planing it. So remember, in mitral stenosis, this is the best method of calculating the mitral valve area. Next, if you are not really sure my mitral valve area is comfortable or not comfortable, we always use this word of continuity equation. What is this continuity equation is? Whatever the blood which is flowing through the mitral valve has to flow through LVOT if there's no MR and there's no air. So what do? We go to 4-chamber view to calculate the mitral valve annulus diameter. So how do we calculate the mitral valve annulus diameter is, we go to 4-chamber view, and 4-chamber view, and measure the annulus size from this point, a hinge point of AML to hinge point of PML. What we get? We get a diameter. Diameter divided by 2 will get the radius. Pi r square is the area across this mitral annulus. And then what we get the VTI from this Doppler spectrum pattern, that is 120. So this is how we get how much blood is flowing through the mitral valve in each stroke. So the area into VTI will give you the stroke volume across mitral valve. Correct? Now we go, now we go where? We go to LVOT. We look at the LVOT, and in LVOT, I'm going to measure my LVOT diameter and LVOT VTI. So what will happen? Whatever the blood flow is happening through mitral valve has to go through LVOT and LVOT VTI. So here's the example of this patient is, I've got an LVOT, they'll give me an area. I've got an LVOT VTI, so it'll give me a stroke volume across LVOT. So LVOT is 3.14, and here is the diameter of LVOT is 2.07. 2.07 divided by 2, square of that, multiplied by 3.14 into LVOT VTI, which is 14.1. There must be 14.1 over here. So this is LVOT area into VTI is a stroke volume across LVOT. Now, how do we get the area? If I get this annulus diameter, which I did mention, or I get a VTI. So what do? I divide this aortic valve VTI to mitral valve VTI to get a mitral valve area by continuity equations. I'll repeat it again. Whatever the blood which is flowing through the mitral valve has to flow through the LVOT in the absence of mitral regurgitation or aortic regurgitation or aortic stenosis. Fortunately, we have an area of this LVOT. We have an LVOT VTI. So how do we get LVOT diameter? We go to LVOT, measure the LVOT diameter, divide by 2, square of that, multiply by 3.14 will give you LVOT diameter. The next thing is, we have got LVOT VTI. We go to 3-chamber or 5-chamber view, put a sample volume in LVOT and get an LVOT VTI. So area into VTI will give you a stroke volume at the level of LVOT. Now we need to have an area as well as VTI across the mitral valve. So we need to have an area and VTI across mitral valve. So what do? We have a VTI with us. We put a continuous wave Doppler across the aortic mitral valve and we get a VTI of 136.2, 120.9. So this LVOT area into VTI, the stroke volume divided by VTI of the mitral valve will give you a mitral valve area. Is that clear?
Hello, sir. Hello.
Yeah.
Sir, I need to ask, what is the use of measuring the diameter of the annular diameter then? Because we are
Annular diameter
calculating
of what?
mitral valve.
Yeah,
Mitral valve annulus.
this is a very answer
Because
is
we are already calculating the VTI of mitral valve, no? And we are
wait a
putting it
minute,
in contributing.
wait a minute. I just wanted to tell you that whatever the blood which is flowing through LVOT has to flowing through mitral valve has to flow through LVOT. We are not measuring LVOT mitral valve this annulus diameter. I just wanted to show you if you have an annulus diameter, if you have a VTI across mitral valve, you will be able to calculate the stroke volume.
Yes.
Correct. So what
Yes,
happens? We do not have an mitral valve area with us, but we have alveolar mitral valve VTI.
VTI.
So
Yes.
if I divide my alveolar area into VTI, divided by mitral valve VTI, what I'll get? Mitral valve
Mitral
area.
valve area. Yes. Okay. Thank you.
So if these are the few features with which we always say that these people are suffering from mitral stenosis, and possibly this is a rheumatic mitral stenosis. I'm not going to talk about all this. This is not in your contention. What are the causes of mitral stenosis? But I'll just name them so that you should understand we are not deal only with the rheumatic mitral stenosis. I showed you rheumatic, I showed you degenerative annular calcification, I showed you hypereosinophilic syndrome. Then we have endocardial fibrolastosis, where the valve will get thickened and endocardium get obliterated. Carcinoid syndrome, sometimes present with left-sided mitral stenosis. SLE, radiation-induced mitral stenosis, mitral valve repair with annuloplasty ring, myxoma when it's trying to get it into the valves leaflet, and then cotriatum behaving like a mitral stenosis. At your level, that's what we need to talk about. Is one more important thing is we need to talk about Wilkinson score. What is that Wilkinson score is? In Wilkinson score, let me just dig out the Wilkinson score for you. This is Wilkinson score is. What is Wilkinson score is? Mobility, subvalvular thickening and calcification. Mobility of the leaflets. Leaflets highly mobile with only one leaflet is restricted is known as grade 1. Leaflet mid and base portion have normal mobility. Tips are calcified or thickened. Valve continues to move forward indirectly but mainly from the base, and there is no movement. It's a subjective finding. Mobility is how much the valve is moving. Then subvalvular apparatus. I showed you the subvalvular apparatus. Is there involvement of subvalvular apparatus or not? Then thickening and calcification. Again, it's basically a subjective finding where thickening is anything more than 5 millimeters, less than 5, 5 to 8, more than 8, or 10 millimeters of thickening on the tip of the leaflets. Then presence of a calcification on the tip of the leaflets, that gives you calcification. Base, we give them a 16 score when we have all these 16 findings. And suppose my leaflets are partially mobile, I'll give them 1 or 2. If my subvalvular apparatus is thickened, I'll give them accordingly. If my thickening is present on the tip of the leaflet, I'll give them accordingly. If the calcification is present, I'll give them accordingly. My scoring would be whatever I score, suppose 2 from this, 2 from this, 2 from this, and 2 from this. It'll be 2, 4, 6, and 8. 8 divided by 16 would be the Wilkinson score. Just remember, why do we need a Wilkinson score? Because this helps in doing a balloon mitral valvotomy, and that's what we always look for, a Wilkinson score. But in our center, we have devised another one edit score is, that's the drop score is. We look at a commissural calcification, give them 4 score. We give them LA appendage thrombus, give them 4 scores. We give them LA thrombus, give them 4 scores. and we give a mitral regurgitation as a 4 score. I'll go back to one of the slides and try to explain you what do you mean by a added drop scores. Whenever you calculate mitral area, so what we think, thickening, calcification, subvalvular apparatus, and mobility. But when we do a balloon mitral valvotomy, we do not split leaflets, AML or PML. We split these commissures. It's like the process of doing a valvotomy is like, suppose this is the whole of a patient is. The balloon goes inside and opens up the valve completely. So it does not split the AML or PML. It splits the medial and lateral commissures. And if there's a lot of calcium in these mitral and lateral commissure is, you're bound to live with a significant mitral regurgitation. Second, if you have a LA appendage thrombus, that's a contraindication. If you have a LA thrombus, that's a contraindication. And if you have an existing severe, moderate to severe MR, the score is 3 or 4, that's again an existing. Because if you do a balloon valvotomy, some of the leakage will always increase. And if you have a resting balloon valvotomy where the regurgitation is more than 2 plus, we already have an existing regurgitation. So the regurgitation will become more than 2. It may go to 2 to 4 or 3 to 4. So that's how it works for a Wilkins score. And with this kind of a points, we can always come to a conclusion. How do my patients behave and what is their issue is whether they belong to my severe, very severe or progressive mitral stenosis. This is what I've made a little bit a different work altogether as far as the valve is concerned. I was trying to say what are the stages of mitral stenosis in the sense who is at a risk of mitral stenosis. Patient doming during diastole, but they have a normal transmitral valve gradients and velocity. Progressive, when the doming is happening, but the area becomes less than 1.5 centimeters square, more than 1.5 centimeters square. And after that is asymptomatic, severe. Area is 1 to 1.5, but patient is not symptomatic. If it's symptomatic, obviously surgery. And the last is severe, very severe mitral stenosis, where whether the patient is symptomatic or no symptomatic, surgery is the only answer, or intervention is the only answer. Either we will go for a valve replacement or mitral valve repair. So if I have to summarize, first thing I said mitral valve cusp separation. Then annulus diameter you can measure in 4-chamber and 2-chamber. Look for echo score in Wilkinson and drop. Mean gradient mitral area by pressure of time, mitral area by planimetry, and preferably by 3 dimensions echo where we can use X-plane or biplane. And you can calculate pulmonary artery pressure in this subset of population, which should be more than 30 millimeters of peak pulmonary artery pressure, not the mean pulmonary artery pressure in this subset of populations. With this, I would like to stop over here and take your questions a little bit. I've exposed you not to the high end of echocardiography. I've exposed you the basic of mitral stenosis. Even if you remember this much in your life, I'm sure you are bound to become a much better expert over a period of time, because I've not touched net atrioventricular compliance. I've not touched the concept of low flow, low gradient in this subset of population. I have not touched the concept of 3-dimensional echocardiography in evaluation of mitral stenosis. So let me ask you to raise your hands. And the first hand is, I can visualize, the first hand comes from Dr. Neeraj Dodke. You can open your mic and speak a little loud so that other people can understand. I may understand too.
Good evening, sir. Sir, regarding the mitral valve annulus measurement and the main points, it is measured in the 4-chamber as well as 2-chamber view. So, are there any standard measurements for that?
Yes, standard measurement. We always look at the mitral annulus time.
So, mitral annulus, do we measure by measuring the diameter? So, what are the references for that? Normal references.
You mean to say values?
Yes, values, yes.
Okay, the values is about 30 to 33 millimeters in 4-chamber
30 to 33 millimeters.
millimeters, 3.3 millimeters, centimeter.
And is there any grading according to
No,
that?
there's no grades.
Okay, sir. So what is the significance, whether it is decreased or uh, does it
Look,
help in?
annulus will never decrease in size, first of all. Annulus will only increase in size in cases of dilated cardiomyopathies,
Okay.
when
So
the
the
heart
measurement is
becomes
required. So measurement is required for at the time of surgery.
correct. Measurements are required for 4-chamber and 2-chamber view by what size of the valve would be required at that particular moment.
Okay. Okay. Thank you, sir.
In echocardiography, to look at the stroke volume at the mitral valve, and in stroke volume, we don't take 2-chamber measurement, we only take a 4-chamber measurement. Dr. Anil?
Sir, what are the conditions where pressure half time is not reliable?
Atrial fibrillation,
No, sir.
tachycardia.
Pressure half time is not reliable in calculating the valve area. Conditions where?
Just a minute. Look at the most important point in pressure half time is not reliable is what? Atrial fibrillation. Ectopic activity. Tachycardia. Non-linear slopes. Sinus tachycardia, atrial fibrillation, non-linear slope. In sinus tachycardia, we always send this patient back with beta blockers. In atrial fibrillation, we try to look for longest deceleration time. I showed you that longest deceleration time. So I'll not take this beat. I'll not take this beat. I'll not take this. I'll see this beat, hold, and click a pressure half time. So I'll do it 11 times to get an average. Suppose this pressure half time is 220. Next is 218. Third is 230. So 218, 220, 230. So same way I'll add all values and divide by the number of values taken by you. And third is non-linear slope. Something like this is a non-linear slope. We have a tall beaking kind of a pattern. We forget about this beaking and we take a line from here, drop to the base. How much time it takes to get to pressure half time. The most important thing is
another question, one more question, sir. How we calculate the LA dimension in MS and what is its importance in relation to severity of MS?
Look, LA dimensions are always calculated in Planck's window. Here we'll calculate the LA dimensions, same Planck's windows.
Okay.
And this Planck's window, if you divide by body surface area, anything more than 22 is considered as dilated. The importance is something like, how can we have a severe mitral stenosis without dilated LA? And as we say the same thing, how can you have a severe aortic stenosis without concentric LVH? Only fact is, if there's associated mitral regurgitation, your RLA will dilate. So that will tell you, look, LA is also to contribute, dilatation is contributed by mitral regurgitations. If there's no mitral regurgitation, no dilatation of LA, then you have to really think twice before you label as somebody as severe mitral stenosis. And that's what I said in the slide of mine. I said, look at the LA enlargement. Severe, large, but mild to moderate in progressive aortic stenosis. Progressive mitral stenosis.
Okay, sir. Thank you, sir.
Dr. Ripan, go ahead.
Good evening, sir. Sir, can you please explain regarding Cusp separation?
Very simple. Look at this film over here. Try to look the maximum opening of this cusp. I'll try to freeze this maximum opening. So whatever the maximum opening of the cusp is, That is known as the cusp separation. From this point to this point, let me try to get you a bigger zoomed up picture. Right. Now you can see this zoomed up picture. So if I take this zoomed up picture over here, so whatever is my opening from this point to this point would be my mitral cusp separation. Look, many people, they do not believe it in. And if you happen to look at my chart, I've gettingly said that it is Giraffe Institutes. And whenever we report, we always report mitral cusp separation. We report mitral area by planimetry pressure half times. We report mean gradient. We report LA enlargement. We look at a peak pulmonary artery pressures and symptomatology, of course. Everybody patient symptomatology would be mentioned in those subset of population.
Thank you, sir. Thank you.
Dr. Neeraj Jodhke again.
Sir, when we say that the calculation of mitral valve area by planimetry is more specific, then when do we need to calculate the area by continuity equation?
Question. What happens, Neeraj? Everything is not straightforward in all the cases.
Okay.
I can quote an example of a patient. His mitral area was 1.2, 1.3.
Okay.
Patient was having recurrent dyspnea, like PND, paroxysmal nocturnal dyspnea. I went in to calculate the mitral area now by continuity equation. And when we calculate the mitral area by continuity equation, the area was not matching with the mitral area by planimetry. Can you tell me what could be the cause in that patient?
Mitral valve prolapse.
Prolapse.
Yeah.
Prolapse is an anatomical feature. Subvalvular appendix. Subvalvular we can see straightforward.
The patient having atrial fibrillation.
Patient having
Atrial fibrillation.
atrial fibrillation was not there because we can see the mitral area and we can see the gradients. It was not an atrial fibrillation.
Capillary muscle infarction or
Capillary muscle, no. See, think something which is associated with mitral stenosis.
Mitral regurgitation may be associated.
Correct. There was a posteriorly directed jet which was seen as mild mitral regurgitation in transthoracic echo was behaving like a severe 1 to 1.5 centimeter square mitral valve area. And how did we do it? We just pushed in a transesophageal probe and demonstrated the severe mitral regurgitation.
Okay. So, in that case, the LA would have been dilated.
LA would be dilated in both the things.
LV would have been dilated.
LV was not dilated by that time.
Okay.
So my question is, your question is very true. When do we do it? Virtually, when I have to do an answer that this patient need a valve intervention, I'll do it virtually in every subject.
Okay.
If you happen to come to my lab, any one of you is, if I get a mitral stenosis, I'll take about 30 to 45 minutes. Yes or no, that's the clear-cut answer. We don't say maybe or maybe, mildly positive, mildly negative, no. Yes, this is there and this is not there. And we could say sometimes, look, we cannot say this is ambiguous. So we need something more. And then we ask for something more to get you a perfect answer.
Thank you, sir.
All right. Next is Tanmay. Go ahead, Tanmay.
Sir, if you please tell us about subvalvular apparatus measurement, means how to take, what to look at.
Do not do a measurements. What we do is we suspect subvalvular apparatus is when we happen to see now look at this valve very carefully. This leaflet is opening up, correct? Dr. Siddiqui, please silent your mic or you are shunted out of it, you know. Nobody listens. They're all educated people. They're open their mic and they're talking to their patients. Does it not look bad? We are not sitting in a sabji mandi, man. And this Dr. Siddiqui, he always does this. You know how much time is required to prepare a lecture? Let's open this class for next time. I would request somebody to take an aortic stenosis. And disturbs the pace of our teaching altogether. So look at this valve very carefully. I did the echo of this patient, and when I was doing an echo, I measured the mitral area. Mitral area was almost 1.8, 1.9 centimeters square. But when we measure the gradients, the previous picture tells you about the gradient. When they measure the gradient's mean gradient was 14 millimeters of mercury. So there's a discrepancy out here. And when we looked carefully over here, we could see a turbulence in this subvalvular apparatus region. Not turbulence over here at the valve levels. The turbulence is in the mid of the subvalvular apparatus. And if you want to really look for the turbulence in mitral stenosis, look, the turbulence is right at the tip of the leaflets. And that's what is a subvalvular mitral stenosis. The answer, why do you want to differentiate between subvalvular and valvular mitral stenosis is, in mitral stenosis, I may go for intervention by balloon mitral valvotomy. But for subvalvular apparatus, I have to replace the valve at every cost, because even if I split these commissions, I'm not going to get benefit from subvalvular lesions. And that's why we look for a subvalvular lesion for valvular stenosis. Dr. Humayr Akhtar, please go ahead.
In case of mitral valve planimetry, we took the measurement in mid-diastole. In case of cusp separation, should we take in mid-diastole or highest diameter we take?
Highest opening.
Sir, in planimetry.
Say it again, then repeat your question.
Oh, sir, in case of planimetry, we took the area measurement in mid-diastole. In case of cusp separation measurement, should we take this in mid-diastole or highest diameter we take?
Both the things, whether is in mitral area or cusp separation, we look at the maximum openings.
Okay, sir.
It's not a question of mid system.
Okay, sir. Sir, I have another question. You show how can we measure the mitral valve area through continuity equation. But in continuity equation, we get the value of mitral valve area in annulus level, mitral valve annular level. But we always measure the mitral valve tip measurement in case of MS. Then should we use the continuity equation for MS?
I'll give you an answer in a better way. Let me just go back to my slide. By continuity equation, I'm trying to calculate my mitral area, not calculating mitral area by annulus. So what I'm doing is, I'm looking at LVOT diameter into LVOT VTI. So this is very clear that you will get a stroke volume across LVOT, correct? Is that correct? Why? This one point is, you are comfortable?
Yes, sir.
LVOT diameter and LVOT VTI will give you stroke volume across LVOT. Now come to mitral valve. In mitral valve, I'm not looking at the mitral annulus diameter. I was trying to explain you mitral annulus diameter. I'm not looking at this mitral annulus diameter. I'm looking at the mitral valve VTI. So what I did, I calculated the mitral valve VTI by putting a continuous wave Doppler across the mitral valve leaflets. So I got the mitral valve VTI. So my mitral valve area is LVOT area into LVOT VTI divided by VTI of the mitral valve. So my question is, whatever the blood which is going through LVOT will form the stroke volume. What is the blood which is going through mitral valve area into VTI? So while calculating mitral area, if we divide this equation from the mitral valve VTI, we'll get the mitral valve area automatically. Why initially I said annulus diameter? I said the annulus diameter is in a normal subject, whatever the blood which is going through mitral valve has to go through LVOT. Stroke volume at mitral valve is stroke volume at LVOT. So what we do is we calculate this stroke volume at mitral valve by looking at this annulus diameter from this hinge point to this hinge point. That gives us an area, diameter. Diameter divided by 2 will give us radius. Pi r square will give us an area. So if I can calculate this area into VTI, I'll be seeing how much is the stroke volume at mitral valve and how much is the stroke volume at LVOT. In mitral stenosis, I need to calculate the area. So I'll not be using annulus. I'll be using only mitral valve VTI, which is seen by continuous wave Doppler across mitral valve. So the equation remains the same. LVOT area into LVOT VTI divided by mitral valve VTI will give you mitral valve area. Is that clear, Humara?
Yes, sir. Thank you, sir.
Sir, in this case, we calculate VTI by pulse wave only, sir.
Pulse wave, if you put a pulse wave, it's a high velocity jet. It may contain the Doppler spectrum pattern or not. But in majority of time, when the stenotic region is, we always switch over to continuous wave Dopplers. Because we are looking at the maximum flow across mitral valve. Okay. So we are not looking at across mitral valve OT, outflow tract. We are looking at the mitral valve area, mitral valve flow VTI. Same thing what we do in aortic stenosis. We look at LVOT VTI, we look at LVOT area. Then we divide that LVOT, this particular equation, by aortic valve VTI to get aortic valve area. And this aortic valve VTI is to get, or mitral valve VTI to get by continuous Doppler. Remember this in your picture is continuous wave Doppler.
Okay, sir. Thank you.
Dr. Mahananda Mahatre.
Yes, sir. Recently, sir, I had seen two patients, may not be related to this, but those two patients had undergone mitral valve surgery, metallic valve replacement, and they had a right-sided heart failure, large hepatomegaly, raised JVPs, and those two patients' 2D echo screening was done, but I could not see any valve opening in the four chambers system. Those were totally fused. So how to measure? They were severely symptomatic with the right-sided heart failure.
It means they have what kind of valve? Single leaflet, double leaflet, or a ball and cage?
Double leaflets they were.
Perfect. If you happen to see the leaflets are not opening up, just look at one important factor is what is their mean gradient across those particular valves.
Okay.
We don't look at an area. We look at the mean gradient across that valve. Then
so
we have
that we should.
Pardon?
From the mean gradient, we should grade the severity.
Yeah, with mean gradient is one of the parameters for severity of the mitral valve in prosthetic position. Then second is we look at the ratio of LVOT VTI versus prosthetic valve VTI. Wait a minute. If I have to show you, just give me a second. I'll stop this presentation over here. That's entirely a different topic. But since you have touched this topic over here, let me just go back and show you the topic. So this is an equation.
Okay.
We look at the peak velocity. Most important thing is a mean gradient. So here, normal has got a mean gradient of 5 millimeters of mercury. Prosthetic possible stenosis 6 to 10. And if it's more than 10 millimeters of mercury, we are always looking at significant stenosis. Then the most important factor amongst all of these is velocity time integral at prosthetic valve divided by velocity time integral at LVOT. So what will happen to prosthetic mitral valve leaflet? If this velocity time integral is more, like the distance traveled by a blood in each stroke, if this leaflets of prosthetic valve is stuck or obstructed, it will have a high VTI at the prosthetic mitral leaflet versus at LVOT. And that is a very good ratio of LVOT VTI versus prosthetic valve VTI. If it's more than 2.5, obviously we talk of a significant stenosis.
Yes, sir.
Things are more or less the same. Things are not different. But the only thing is they change from circumstances to circumstances.
Yes, sir.
If you look at this particular phenomena, what exactly we have done? Peak velocity, mean gradient, velocity time integral, and pressure half time. And only thing is we have talked about effective orifice area. What do you mean by effective orifice area? We do the same thing. We go to LVOT diameter, we go to LVOT VTI to look at the stroke volume across LVOT VTI. Then we divide that LVOT stroke volume by prosthetic valve VTI to get effective orifice area at the mitral valve levels.
Okay.
But in prosthetic valve, we don't say area. We say effective orifice area, or we can say prosthetic valve area. Means how much the prosthetic valve is opening.
So that is effective orifice area.
Effective orifice area.
Okay, sir.
So whatever we taught you right in the beginning for 4 lectures, if you put all those things together in your practice, believe my words, only thing you have to remember these figures. And very different ways remember this figure is just print them up, get them laminated, and put in the walls of your echo labs.
Okay, sir.
Right?
Yes, sir. Thank you, sir.
Thank you. Take care. Next is Dr. Baljit Kaur Sira. Dr. Baljit, please go ahead.
Sir, I have one question, sir. Sir, you said that while there is a increased gradient, we shift to continuous wave Dopplers. So we calculate the VTI by continuous wave Doppler, sir. Sir, can we calculate the stroke volume as well?
Can you repeat your question again? Let me understand.
Sir, when we apply the continuous wave Doppler during increased gradients, so we calculate the VTI with the same. Since in last to last question it was brought up that it is calculated by continuous wave Doppler. Sir, can we calculate the stroke volume with the same, sir?
Obviously.
So then there was a question in the paper that you said that continuous wave Doppler is used for all except you said the answer is stroke volume, sir.
Okay. Now I got what you're trying to ask me. One point is pulse wave Doppler versus continuous wave Doppler. Correct?
Yes, sir.
Now, what I said as stroke volume is, if we do not specify anything in stroke volume is, that stroke volume is LVOT stroke volume.
Okay, sir.
So, first question is stroke volume. If I'm saying pure stroke volume is LVOT VTI by pulse wave Doppler at LVOT and LVOT diameter. That's what the stroke volume is. If I use this LVOT stroke volume versus aortic valve, they'll give me aortic valve area. But aortic valve is a continuous wave Doppler because aortic valve gradient are very high.
Yes, sir.
So what you can do is, Dr. Baljit, next time, tomorrow, what you should do, take a normal subject.
Yes, sir.
In normal subject, you calculate LVOT VTI and LVOT diameter giving rise to area. So they'll give you a stroke volume across?
Yes, sir.
LVOT.
Across LVOT, sir. Yes.
Now you go to aortic valve level with pulse wave Doppler spectrum pattern at the aortic valve levels.
Okay, sir.
So what will give you?
Sir, it will give VTI and
It'll give you aortic valve VTI.
VTI, yes, sir.
Correct? But in a normal subject. Suppose
Yes.
that valve is stenotic, whatever you do, you cannot contain that Doppler spectrum pattern.
Yes, sir.
So in normal subject, once you take that LVOT VTI, aortic valve VTI, you divide by aortic LVOT stroke volume, you will get aortic valve area.
Yes, sir. Yes, sir.
But whether it's mitral stenosis or aortic stenosis, in those cases, this particular pulse wave will not be valid, because if you do a pulse wave, you will not be able to contain the Doppler spectrum pattern because of a high flow velocity across aortic and mitral.
Okay, sir. So means wherever we see stroke volume, that means LVOT stroke volume.
Correct.
Okay.
Unless
Thank-
until specified.
that is what I was confused with. Thank you, sir. Okay, sir.
And one more thing, I'll say thank you to you for one more reason. My next paper will always say LVOT. When I will write LV stroke volume, I'll always mention my LVOT one.
Okay, sir. Okay, sir.
Dr. Sachi Surendran.
Sir, good evening, sir. The continuity equation is not valid when the patient is having AR. Am I right, sir?
If a valve is leaking, how can you say that this equation would be valid? But at the same time, this equation would be valid in MR also, AR also. I cannot calculate aortic valve area by, or mitral valve area, mitral stenosis, aortic stenosis by continuity equation when AR and MR is present. But in cases you have an AR, suppose to take an MR. So what I'll do, I'll calculate a stroke volume at mitral valve level. I'll take an annulus diameter. I'll do a pulse or continuous wave Doppler across mitral valve to give me a stroke volume at mitral valve level, right? Then I'll go to LVOT to calculate LVOT stroke volume. So if my mitral valve is leaking, the amount of a stroke volume at mitral valve would be more than the amount of stroke volume at LVOT. So mitral valve stroke volume minus LVOT stroke volume will give me regurgitant mitral valve stroke volume. Regurgitant mitral valve regurgitation volume. We'll teach you this more. But when you talk of this MS, when you talk of AS, if you have an associated MR, if you have associated AR, this thing will not be valid. Mild we accept, but moderate or more will not be accepted for calculation of stroke continuity equation for mitral valve area. But why do you want at your level? We only do all these kind of a thing when we are not comfortable with our own work. Look, for you, I do not know what exactly the issue is. You are a beginners. But when the patient comes to our lab, believe my words, it's killing for us number of times. We just cannot say no because we have to give an answer to this subset of population. Look, this is severe mitral regurgitation or this is severe aortic regurgitation. We have to do a surgery. And on top of that, we have to tell them what kind of a surgery it is required. And when we are not comfortable, then we use all these kind of a different method. At your level, remember a very simple thing. If you have MS, you have a mitral valve area. Except for the fact the supravalvular and subvalvular stenosis should be left alone. Just remember to begin with. But I'm happy. You're putting your mind together to think of beyond the boxes.
Okay, sir.
I'm really happy about that, Sachi.
Thank you.
Dr. Humaya Akhtar, please go ahead.
Recently, aortic patient, she has severely calcified mitral valve with restricted opening. PML are fixed and AML doming is also present. And on planimetry, her mitral valve area was 0.8 centimeter per square, but and her anterolateral commissure are calcified and fused, and posteromedial commissure are partially fused. And on gradient, mean gradient was 5 millimeter of mercury, and maximum gradient was 7 millimeter of mercury, and her LV systolic function was normal. Then how should I classify this patient? Very severe or mildness?
As far as gradients are concerned, that belong to progressive mitral stenosis, first of all.
Yes, sir.
Correct. But mitral area, what you said is
0.8 centimeter square.
correct. Why you're facing a problem of mitral area as a smaller area? I'm sure like you are excluding two important things. He does not or she does not have any subvalvular thickening or supravalvular lesion, correct?
Yes,
and
sir.
whatever you said, lot of calcium. What was the age of this patient?
38 years.
38 years. So if I would be in your place, in this case, what is the lacuna would be you'll be facing is whatever the mitral area you are calculating in this patient with lot of calcium is, you're always underestimating your mitral area. Why you're underestimating your mitral area by planimetry is because a lot of calcium gives rise to reverberation kind of a picture where you underestimate this area. My quest with you is go back, look at the area by pressure half time and do it as many times as possible, 8, 10, 12 times. Same thing, you take that patient to a 3 dimensions imaging window and do a cut right at the tip of the mitral valve leaflets. And when you get a best image, just go for a zoom up and calculate by mitral area by planimetry by optimizing the image. Third is utilize my mitral valve continuity equation. And once you do all these kind of things, I'm sure you will have a real correct area of the mitral valve lesions. And still you are not comfortable with this kind of a thing, ask one of your colleagues to put a transesophageal probe to look at a mitral area by planimetry in team.
Okay, sir. Thank you, sir.
One more thing. What was the peak pulmonary artery pressure in this patient?
27 millimeter of mercury.
Then I'm very sure your mitral area 0.8 is underestimated. If somebody has got a severe mitral stenosis, the peak pulmonary artery pressure has to be more than 30.
Okay, sir.
Dr. Samsul Kamar. Samsul, we cannot hear you at all, man. You have to speak a little louder. No, go ahead and speak louder. Something to do with your mic. Are you using a mobile or you're using your laptop? Now you're, now you have unmuted yourself. Okay, dial my number 9811013246. I'll let everybody question your answer. Then I'll reply you. Call me on my number 98110. You are from Bangladesh, right? Call on a WhatsApp call +91. It's here. Don't worry about it. I'll switch it on. Just give me a second. It's what switched off for a second. I'll just switch it on. Just give me 2 more minutes. Let it. Then I'll come back to you. Dr. Mahananda Matre, go ahead. Dr. Matre? Okay. Dr. Sachi Surendran, any question you want to ask again?
Sir, I have a very simple question, sir. In patients generally above 35 or 40 years of age, typical Indian patient, if there is an absence of mitral stenosis, and if the patient has atrial stenosis, aortic regurgitation with mitral regurgitation, can it still be rheumatic in origin, sir?
And for whatever I could understand, you say that patient is about 40 years of age, has got a mildly increased flow velocity across mitral valve in mitral regurgitation. How do you attribute that? Right?
Yes, sir. Sir, yes, sir. Right. How do I attribute the rheumatic aortic disease, sir, in the absence of mitral stenosis?
This is, you always look at only specific thing of a doming of a diastole. That's all.
Okay.
Doming or no doming, that's differentiate complete the mitral stenosis.
Okay, sir. Sir, but the patient was not having mitral stenosis. He was
Go
having
ahead
only
now.
mitral. The patient was not having mitral stenosis. The patient was having only mitral regurgitation with aortic stenosis and aortic regurgitation.
Samsul, go ahead, speak loudly. Yeah, we can hear you. Go ahead. How do you identify what? Okay, very good. His question is, how do we differentiate between a person undergoing a valvular dilatation versus MVR? It's a very simple thing. If you have subvalvular apparatus involvement, obvious surgery. Supravalvular, always surgery. But as regards valve is concerned, the thickening is acceptable. Calcium is not acceptable at the commissure's level. So we give them a 16 score model. So if you have a score of 8 or less than 8, divided by 16, 8 by 16 is acceptable for balloon mitral valvotomy. 8 means what? Thickening could be 2, calcium could be 2, subvalvular apparatus 0, and mobility. So if you have a 2 thickening, 2 calcium, 1 subvalvular apparatus, 3 mobility, that comes out to be 8 as a Wilkins score. So 8 out of 16 is acceptable. Now my question is, what we do in balloon valvotomy? We do commissurotomy. We do not do balloon valvotomy. The name itself is wrong. So we split the commissures. So we focus on commissure. If the commissure has got calcium, and that's what we said, commissural calcification in Jalop score is, if there's a significant calcium in commissures thickening, as Dr. She was asking from Humaira was asking, she was underestimating at 0.8 as a mitral area in planimetry in calcified valves. So if you have a significant calcium in 3/4 score, I'm not going to do a valvotomy. If I've got LA thrombus, I'm not going to do a valvotomy. Even if a depicted LA thrombus is there, I'm not going to do it. If there's LA appendix thrombus, I'm not going to do a valvotomy. Because as soon as I do a valvotomy, thrombus in LA appendix as well as in LA will get liberated to systemic circulation. Fourth thing is, if I have an existing MR which is moderate, if I do a valvotomy, the moderate MR will become certainly significant as severe mitral regurgitation. And the patient has to go to valve replacement immediately. So 8 by 16 score of Wilkinson's, 2 or 3 of commissural calcification, 1 by 4, even 1 by 4 of LA appendage or LA thrombus, plus 2 by 4 of MR will deny that patient to go for valvotomy. So remember, not 4, remember 8 of these findings to be scoring for valvotomies. Is that okay? All right, let's move to Dr. Anil.
Sir, in functional MS, which method is reliable for calculating the...
What do you mean functional MS?
Sir, in case of AR, mitral valve cannot open because of compression by the jet of AR.
What will happen to mitral valve? Peak mean gradients.
Yes, sir.
What will happen to mean gradients? the mean gradient would be almost normal, man.
Yes, sir.
So I never said peak gradients. I said mean gradients as a method.
Okay, sir.
Anything else, dear? Neeraj,
Okay.
Sir, if we calculate the mitral valve area by planimetry, and so what, and by pressure half time, so what is the acceptable difference between the two areas? In other words, like how can we confirm that what we have calculated by planimetry is correct at our basic level?
In a patient, there should not be a significant difference in planimetry versus pressure half time, because if at your level, if there is no tachycardia, no atrial fibrillations, there should not be any difference between these two. But if you happen to find a discrepancy between planimetry and pressure half time is, you have to spend more time on planimetry rather than more time on pressure half time. And try to calculate pressure half time at a time when patient is in normal sinus rhythm with a heart rate of 70 to 90.
Okay, so can it be so can it be a standard against which we can compare our planimetry?
There cannot be a standard. If you happen to have a planimetry area and pressure half time area is, then you look at other parameters, mean gradient, LA size, then continuity equations, Cusp separations. There is nothing like a standard between these two.
So it is only with experience it will come.
No, experience is very important. On top of that, these G machine or Philips machine with 3 dimensions imaging have made this experience very simple.
No, sir, but at our level, when we don't have that 3D this thing.
And I was a student like you know what I used to do? I put my patient on the back of my scooter and take to a place where 3-dimensional machine was available.
Okay. Okay, sir.
Now you'll not do it against Prestige.
Okay, sir. Thank you.
Dr. Mohammed Arif.
Good evening, sir.
Good evening.
Sir, you showed multiple images for the mitral stenosis. Could you please give one example, sir, for calculating the Wilkins score by that image?
Sure. Now look at thickening first. The thickening is about 5 to 8 millimeter normally. And if I have to classify as thickening, I'll divide this between 2 or 3 of Wilkins score. Mobility is restricted. It's about 2 to 3 again. Calcification, I hardly see any speck of calcium on this mitral leaflets. So I'll try to hold my calcium as maybe 1, somebody will say, 3 thickening, 3 mobility, 1 calcium, and subvalvular apparatus is almost 0. So 3 plus 3 plus 1, 7 by 16 segment model. Now get to drop score. We have LA thrombus out. Look at the LA appendage thrombus out. Third, if I the amount of a severe regurgitation, moderate plus regurgitation out. And then finally, I'll go to short axis view to look for a commissural calcification. Look, there is no commissural calcification over there. These are the lateral commissure. This is the medial commissure. There's only speck of calcium over here. This is a majority of time is fibrosis. So as far as commissural calcification is concerned, I'll say 1 by 4. If I talk of a thrombus in LA, it's whatever you say, LA 1, 2, 3, 4. I'll say 4 by 4. Look at the LA appendage thrombus. That's what be there. If it's there, 4 by 4. Or whatever. I say yes or no in LA and LA appendage thrombus. Only thing is, if the amount of moderate regurgitation is present, I'll put as 2 by 4. So LA and LA appendage thrombus is in G7, they are the vetoes. as far as doing, I say let's put this name as G8. In G8, two are the people who are a complete vetoes, LA appendix thrombus.
Yes, sir.
Mitral regurgitation, 2/4. 1/4 is acceptable, 2/4 become dicey, and 3/4 is moderate to severe, becomes really contraindicated. And calcium scoring at the annulus is like variable from 1 to 4. So 6 segments, you can say very category, you can calculate them. But if you have LA thrombus or LA appendix thrombus, that's a veto for any doing a balloon valvulotomy.
Yes. Thank you, sir.
Right. Arif, you are
Yes,
done.
sir. Thank you, sir. Yes, sir.
Dr. Muhammad Ali Qasim.
Good evening, sir. Can you hear me?
Yeah, I can hear you, Ali.
Sir, sometimes we find in case of mitral stenosis, there is commissurals are partially fused. So what will be our approach in case of this patient?
If commissions are fused, they are not calcified. I'll go and open them up.
Partially fused in case of?
Fusion is accepted. Calcium is not accepted.
Okay, sir. Thank you.
Dr. Tanmay Roy?
Sir, if there is any role of mode measurement to look at the etiology of mitral stenosis or to look at the degree.
Tanmay, you are asking me in the era of 2024 driving a Maruti car.
Okay.
There are so many things are there. When a battery car is available, why do you want to go and buy a Maruti 800 now?
Okay. Okay, sir, actually you just mentioned about EF slope D.
I do mention, I just did mention because I knew that someone like you will ask me this question.
So, sir, these are not useful now.
They are useful, but look, this only guides you. Look, today is the era of quantitation. Today is not of qualitation.
Okay.
And I can give you a mitral area. What else you want a DF or EF slopes?
Okay, okay, sir.
When there are
Actually,
five
sir,
parameters.
yes. Yes, sir. Actually, sir, to differentiate between functional mitral regurgitation and if there is any restricted movement, is there or not, then I think a mode measurement is somewhat helpful. Sir, if you have any opinion about it, sir.
Look, this patient has got MS and MR, both of them. Can you say that MR is there in this patient or not? Without color Dopplers.
Yes.
I say yes. Its MR is not there. Okay, let's take a vote. So people can say yes. They can raise their thumbs up for yes. MR would be there or not there. Let's see how many of you raise your hands. Thumbs up. 1. MR is there. Tanmay is 1. Anil is 2. Oh my God, many people MR. Aris, you want to say yes or no?
Yes, sir.
Okay, 1. Vandana Kumari. 2, 3. The rest of the people says this is not there. Shripat Kore says it's there. Very few people says MR is there. Anyway, let me ask one of the person why they say MR is there. So those guys who have raised their hands. Arnab Chaudhary, why the MR is there, Arnab?
Sir, LA dimension.
Because it is dilated hugely.
LA dimension is very much dilated, sir.
Okay.
LV is not dilated, so MR may not be there.
Sir, echo contrast fluid is moving. That echo contrast Blood.
Who said this word, echo contrast?
Arif.
Arif. Arif, if there would have been a severe MR, this echo contrast would not have been there. Because MR will not let this echo contrast stay over there. It will, like, suppose your water is stagnant. If you put a hand inside the bucket and stir that water, the stagnation, this is stagnation of blood flows.
Yes, sir, yes, it will go.
So whenever you have an MR, you will not able to find a clot or a thrombus. LS size enlargement is not there anymore. But I do agree, LV enlargement is not there. The chances of MR is less. So what he was speaking about MR is, whenever we see a restriction of motion, and along with that, if we have an MR, we'll get a better idea. If you have a restriction of motion, it could be anything. It could be MR or MS. Severity could be anything. It's nothing to do with the restriction of motions. All right. So, Mohammed, now it's done. I think that question is done already. Any questions again for mitral stenosis? Let me just quickly finish on my tricuspid stenosis. Arnab, you want to ask something? No. All right. So let me stop over here for mitral stenosis. And tricuspid stenosis is very easy. Believe my words, it's the easiest thing you can ever do. Two dons are in waiting areas. Mangesh Dande Don, Mangesh Dande Don. Lord Mangesh, you are in waiting area at 10 o'clock, 10:30? You have rejoined or you just joined?
I joined it right time. Or I joined it in the beginning. It was disconnected from my internet connection.
Okay.
I mean, since the beginning.
All right, all right. I appreciate.
Okay, sir. Continue.
So let me just go and quickly finish up tricuspid stenosis. Not a terrific topic. It's a very small topic. Once we have done a tricuspid valve, stenosis would not be a difficult thing. All right. If you look at a tricuspid valve, we have a look at the anatomy of a tricuspid valve. What we see in focused RVRA view, we septum and anterior wall, and sometimes we see a posterior wall also. But for sure, when we go to short axis view at aorta, either this is septum or anterior, but the other value is always posterior wall. Here, because of the cut section, by doing a zoom either toward anterior or posterior, we can do a mitral valve area as, tricuspid valve area as anterior and posterior. You can understand with this picture. If I'm cutting over here, if I cut in this direction, I'll be cutting septum and anterior wall. If I'm cutting in this direction, I'll be cutting septum and the posterior wall. That is focused RVRA view or our four-chamber views are. So hence, this is always septum wall, but this is anterior or posterior. But what sure is, when we go to short axis view at aorta, this is always posterior wall is. So if somebody asks you, which is the valve which is involved in tricuspid valves, we can say septum is always straightforward, anterior in four-chamber view, but posterior is always in short axis view. But on the other hand, you go RV inflow view. The valve which is closer to right hand side is always anterior valve. Other valve is always septal valve. So if I would be in you or positions, I'll not focus in RV, focused RVRA view. I'll focus in short axis view and RVRA inflow view. So right side, I'll forget the short axis view. I look at the left side, that is always a posterior wall. I look at the left side, this is septum and this is anterior view. So I can identify all three leaflets in tricuspid wall. Next is, what is severe mitral tricuspid stenosis is? This is identical to mitral stenosis only. Only thing, we see a turbulence at the mitral tricuspid valve level. And give me a second, I'll show you a very interesting finding which is seen in this patient. And you will never forget to understand which is the significant lesion. And this is valid virtually in every subject. And is not commonly seen very easily. I'll focus and tell you what is the lesion is. So I'm focusing. Look, what do you see over here? Anyone can open their mic and tell me. You see a pizza formation on this atrial side of tricuspid valve.
Vena contractor.
We can say vena contractor, but this is a pizza formation. And if I go towards mitral valve levels, tricuspid valve level, there's also pizza formation over here. Now you cannot say the pizza is not formed very clearly over here. So in both the cycles during systole and diastole, we have a pizza formation. And now we have to be more sure on one side the pizza is there or not there. Here, the pizza is not clear, but I can say very confidently, my pizza is very clearly seen on atrial sides. Wherever the side pizza is formed, the opposite side is a significant lesion. So in this patient has got a TS with TR. But my question is, this patient has got a significant tricuspid stenosis. Because the blood will accelerate. Here's the blood will accelerate to go through this tricuspid valve. This is known as flow conversion. This is vena contractor, and this is the outflow where the flow disperses or opens up. So this flow conversion ultimately leads to a vena contractor, and this is hemispheres will tell you, look, all the blood is rotating or churning around to this hole. And the best answer is tomorrow morning, take a bucket of water, put it in a wash basin. And as soon as you put in a wash basin, you will find multiple swirling rings in the wash basins. And those rings are almost the same rings as we see over here in this pizza in two dimensions. All right. As soon as we see this pizza formation, what do? We see a restriction of this cusp motion. So when we see a restriction of these cusp motions, then we put a continuous wave Doppler and we trace this continuous wave Doppler and gives you a mean gradient of more than 5 millimeters of mercury or 5 millimeters of mercury. So increase in peak and mean gradients and gradients across this flow pattern is considered as severe tricuspid stenosis. Thickened, distorted, doming in diastole, valve area less than 1 centimeter. I'll tell you how to do it. Then pressure half time more than 190 millisecond and a mean gradient of more than 5 millimeters of mercury is considered as severe tricuspid stenosis. If you happen to look, what will happen as a secondary features for tricuspid stenosis? What will have? We have what? RA dilatation. What will have? IVC dilated. What will happen to integrated septum? It will bulge towards left-hand side. So all these features, they are secondary features for tricuspid stenosis. If you happen to have a dilated RV with this kind of a regurgitations, then start looking for what? Severe tricuspid regurgitations. And the classification of tricuspid regurgitation is based on two important things. We look at the vena contracta. Less than 3 is mild, 3 to 7 is moderate, more than 7 to 14 is severe, 14 to 21 is massive, and more than 21 is torrential tricuspid regurgitation. And then we put a continuous wave Doppler to calculate inflow gradients and regurgitant gradients. Here the regurgitant gradients we have not calculated, but it's somewhere 2.5 to 3 meters per second. So we are more focused on this tricuspid stenosis, where you draw pressure half time, and pressure half time will give you a mitral tricuspid valve area. And this pressure half time tricuspid valve area, along with RA IVC enlargement, and along with them, the mean gradient of more than 5 millimeters of mercury will give you a tricuspid stenosis. If I have to comprise tricuspid stenosis in one go, I said all is true except one. Thickened leaflets, turbulence across tricuspid valve, mean gradient between 5 to 10, pressure half time more than 190, dilated RA and dilated RV. Dilated RV is never present in RV in tricuspid stenosis. So this is what all tricuspid stenosis is not a rocket science. It's a very simple thing which we do. If you have understood our mitral stenosis, the tricuspid stenosis is very, very simple to understand in day-to-day practice. My only quest to all of you is, if you happen to see one lesion, don't get satisfied that you are done with one lesion. You don't need to look at another one. If you happen to see one lesion, always search for second lesions. In very simple word, when you were in medical college, whenever you loved some girl, you never used to look for that girl alone. You look for the friend of that girl. Where is that girl is? The same thing happens over here also. If you happen to see one lesion, always see the friend of that lesion is. Is there any other friend of the lesion is lying in this echo picture or not? I can quote an example where I saw a patient who had mitral valve replacement done, but he was left behind with tricuspid stenosis, tricuspid regurgitation, and forgot the name of the entity, where the tricuspid or RA was divided into two parts. So they just look at the mitral valve and forget about rest of the pathology on the right hand side. So this is how we have to look at. Don't look at your girlfriend. Look at the friend of your girlfriend. She must be around here. And when you do this kind of a thing, believe my words, you'll be able to do a good cardiology rather than doing a simple cardiology, which most of us do and may ultimately make some mistake in day-to-day practice. With this, any questions before we stop over here? It's almost 11 o'clock. And I'm sure many of your wife must be cursing, or many of your husband must be cursing Dr. Rakesh Gupta at this moment. Muhammad Ali Qasim.
Sir, in case of, sir, you have told some membrane in the RA. In case of RA membrane, some communication is there present. Is so, sir?
Yeah. I just forgot the name. I'm sorry, I just did not remember the name. If you allow, co-tritum dexter.
Sir, there is a communication gap between the membrane and
this is co-tritum dexter.
Sir, there is a two chamber in
superior inferior chamber. Superior chambers were draining the SVC, the inferior chambers were draining the IVC, and there was a membrane with a small hole. So they left the membrane, they left the tricuspid valve as it is. We cannot go back and do the tricuspid valve replacement. Of course, I can do with the co-tritum dexter on the right side. Just take a balloon out there and blow it off. Yes, but tricuspid valve, obviously, I need to fix a tricuspid valve. And unfortunately, in tricuspid valve, you cannot do a balloon valvotomies. In tricuspid valve, obviously, we have to replace with low-profile biological tricuspid valve leaflets, either porcine or bovine, depending on the religion. I cannot give up bovine, porcine, and porcine or bovine valves as per Muslim and Hindu cultures.
sir, in case of dysplastic tricuspid valve, what will be the feature?
Dysplastic is a regurgitation. We'll discuss with that. Give us some time.
Okay, sir.
Anybody
sir,
else?
Sir, this is Neeraj.
Go ahead, Neeraj.
Sir, I have a query. Like this is apart from the today's lecture. I missed the last explanation of last 7 questions in the last explanation of the exam because of the internet issues. So, what can be done for that?
Neeraj, I just go. I'll send you the video recording.
Thank you, sir. Thanks a lot.
Reena, I must have sent it to all of you, the video recording, man.
No, sir, we couldn't get it, sir.
Okay, I'll make them. She'll send you tomorrow, definitely.
Thank you, sir.
Let me just check whether I have recorded or not. That's also a big issue.
Maybe, sir.
Otherwise, I'll explain you. That's not a problem, Neeraj. Anytime.
Yes, yes, sir.
All right, guys. I hope you had a good time today. Always a stenotic lesion. And we are going to have 2 more stenotic lesions next week before we start regurgitating for next 2 weeks. So this is the time to go back, enjoy your dinner, and say regards to your respective spouses. Thank you very much for sparing your time for us. Good night, Shabba Khair, stay safe. See you next week at the same time with another session of 49th Comprehensive Course in Echocardiography. More of a stenotic lesion, less of a regurgitation. To stay back, we are there next week, definitely at the same time. Bye-bye. Good night.
Thank you,
Thank you, sir.
Thank you, sir.
Thank you, sir.